Thank you, Dr. Rafi. It was indeed a pleasure to be introduced by a dear friend and colleague. Well, to cut it short, let me start the topic. I believe there's a handout given to all of you, and this handout has two parts. One is a very brief MCQ questionnaire, and one is a speaker evaluation form. I do request everybody to fill up these forms. The speaker evaluation form is quite critical because they may be asked to submit it for our CME evaluation so that we get the CME hours. So please don't neglect that. Please do fill up the speaker evaluation form and leave them on the table when you leave. Let me start with the questions. There were 4 questions that I had mentioned in that paper. The first one is, what is the prevalence of pediatric psoriasis? The reason for this question is, what are we dealing with? Why should I talk on pediatric psoriasis? Is it something really worth talking on? Do you really see pediatric psoriasis in the clinic? And if so, how frequent is this? So that is a question that is pretty critical, because unless you know the burden, the volume of patients you are likely to see in the clinic, there is no point in going further. So the question is, what is the prevalence of pediatric psoriasis? 2% of the population, is it true or false? 2% of the population is a huge number, believe me. So is it really true or false? The second question, 1/3 of adult psoriasis patients have an onset during childhood. Is this true? We all know psoriasis has so-called 2 peaks, type 1 psoriasis and type 2 psoriasis. The type 1 coming around the age of 20 and the type 2 coming around the age of 50. But is it true that when we see adult psoriasis patients, nearly 1/3 of them have had an onset during their childhood itself? Is this true or false? The third is it equal in men and women, or is pediatric psoriasis more common in girls than in boys? Is this true or false? We'll come to the answers in the end. The last is pediatric psoriasis static in prevalence, or are we seeing an increase in the incidence which is adding on to the prevalence? Is there a sequential increase over a period of time? The second question is about clinical presentation. Is gutted psoriasis the most common presentation of pediatric psoriasis? Is this true or false? Is unresponsive diaper dermatitis psoriasis true or false? Next, streptococcal infection is a common trigger of gutted psoriasis. Is this a true statement or a false statement? The next, plaque psoriasis can present on the face and around the eyes in children. Is this true or false? The next one, is arthritis more common in childhood psoriasis than in adult psoriasis? Is this true or false? The purpose of these questions is to stimulate your mind and make you aware about the issues of concern in pediatric psoriasis. So we'll go to the next part. How do you diagnose pediatric psoriasis? Is this a primarily clinical diagnosis? Is this true or false? Do you need to do a biopsy always? The second, can we make a diagnosis by a dermoscope? Is this true or false? The next one, a complete diagnosis requires a complete evaluation of all the comorbidities of psoriasis. Is this true or false in childhood? The last one, of course, I already mentioned it, do you always need a biopsy? When it comes to the evaluation, metabolic syndrome is only an adult issue. Is this true or false? Do you see it in children? The parameters to diagnose pediatric metabolic syndrome is similar to adults. Is this a true statement or false statement? The role of the psychologists and counseling is important in pediatric psoriasis. True or false? And family counseling, registry maintenance, and long-term follow-up are important in pediatric psoriasis. True or false? So this is one set of questions. When it comes to management, needs a combined effort of multiple specialties. Systemic treatment is considered only after due diligence, and phototherapy is the mainstay of treatment of pediatric psoriasis. Systemic immunosuppressive treatment is licensed for severe pediatric psoriasis. And the last question, biologics are licensed for severe pediatric psoriasis. So I finished the uncomfortable part for me when I have to look at a slide and read. So let me come to the comfortable part. I don't need to look at the slides. So without much ado, let's go to the First thing, I do have some disclosures. I have been a speaker for various companies. That has nothing to do with what I'm going to say right now. And let me say that the objective is to open your mind about pediatric psoriasis, how we diagnose it, how we treat it. And the presentation has this flow. We will talk about the epidemiology, the pathophysiology, presentations, comorbidities, management, the biologic treatment options, and highlight on a study on adalimumab in pediatric psoriasis. So, epidemiology. Nearly 2.5 to 3% of the population has psoriasis. Okay. This everybody knows. 1/3 of adults have had their onset of psoriasis when they were children. So this is a very important point to know. The third is up to 2% of prevalence of psoriasis in pediatric age group has been discovered. Of course, it depends on which part of the world you study in. And of course, the age of onset of psoriasis varies right from the neonatal period up to the age of 18. Congenital psoriasis, or true congenital psoriasis, is psoriasis which is seen before birth or within the first 24 hours of birth, which is very rare. Whereas pediatric psoriasis is something that we see up to the age of 18. Of course, in Germany, they discovered that girls have a more higher incidence than boys, whereas studies in other nationalities haven't proved this. So possibly that the incidence between girls and boys is more or less equal. And when it comes to the increasing incidence, of course, there's a clear-cut increasing incidence of psoriasis possibly due to various reasons. When you come to the prevalence, you see the age group. You see there is a gradual upslope right from the age of 4 to 5 or to the age of 55, and then there is a so-called plateau. So it is not as if psoriasis is a type 1 psoriasis and a type 2 psoriasis which occurs in two particular age groups. It is something that we see as a spectrum over almost all age groups. How does psoriasis present in children? Plaque psoriasis is the commonest form of psoriasis in childhood. It is not guttate psoriasis. And plaque psoriasis is seen in almost 34 to 84% of cases. Of course, guttate psoriasis can be seen in 6 to 44% of cases, and it might eventually convert into plaque psoriasis. As all of you know, guttate psoriasis is a type of psoriasis where you have teardrop shaped small patches and plaques, which actually may be triggered by an infection which may be streptococcal in nature, and of course viral infections, but commonly streptococcal. And psoriatic diaper rash, a so-called rash which presents in infancy, which does not seem to go away with any form of treatment, and whether it is steroids or whether it is antifungal, we should trigger us to think that this might be psoriasis. And this is common in children below the age of 2. Pustular and erythrodermic forms of psoriasis are extremely rare, but we do encounter them, and sometimes they can be life-threatening conditions. Arthritis is much less frequent in pediatric age group than in the adult age group. In adults, it can approach 25 to 30%, whereas in the pediatric age group, it is approximately 19%. So, how does it present? So, various studies have shown that the presentation of psoriasis in childhood can be slightly different as compared to adults. The redness may be slightly more. The thickness of the plaques are much less than in adults, and the silvery scaling is not so thick. And even though the scalp and the extensor aspects of the elbows and the shins are quite a common location, inverse psoriasis, that is plaques occurring in the body folds, and the involvement of the face and especially patches, red patches around the eyes, are a hallmark of psoriasis in childhood. And name changes are seen in up to 40% of children. Diaper rash is thought to be a Kubner phenomenon. As all of you know, the isomorphic phenomenon where injuries induce skin lesions is a well-known factor. As all of you know, psoriasis is an immune-mediated inflammatory condition, and once the cytokines or the chemicals are triggered by injury, for example, in the diaper area, you do get patches there. clinical manifestations, boys are less likely than girls to report scalp involvement and are more likely to have nail involvement. Rest of it is already mentioned. When you come to the types of psoriasis in the pediatric age group, like I mentioned, plaque psoriasis is the most commonest type, not the gutted one. Diaper rash is seen in 12%, almost. Scalp, anogenital, gutted. Of course, the rarer forms, acropustula. When eczema and psoriasis overlap, what I would like to say is that, see, many times when you do a biopsy, we get a report saying that we are dealing with a psoriasis form, dermatitis. And the cytokines and the cells involved in atopic dermatitis and psoriasis do overlap. And it's a well-known fact that we may be having an overlap of psoriasis and atopic dermatitis in some patients. And it is well known that the genotypic and phenotypic manifestation of atopic dermatitis, especially in the Asian population, has psoriasiform characteristics, both in the skin, morphologically, and when you come to the cytokines also. So Th17 predominates in the Asian phenotype of atopic dermatitis, and possibly there is a so-called overlap between eczema and psoriasis. The face plaques, of course, are quite a feature of psoriasis. Palms, soles, of course, are well-known locations. Pustular psoriasis is rare, but can be quite a severe issue. The nails are involved, of course. Erythrodermic psoriasis is a rare condition. A few pictures. Comorbidities. So, in fact, comorbidities of psoriasis are more common in the pediatric age group than in the adult age group. And you know that psoriasis is associated with hypertension, diabetes, hyperlipidemia, obesity, ischemic heart disease, rheumatoid arthritis, juvenile idiopathic arthritis, Crohn's. So, the percentages of involvement, prevalence of comorbidities in children compared to the adults clearly demonstrate that the comorbidities of psoriasis in the pediatric age group is much more than even in the adults. Therefore, psoriasis is not just a skin disease. The so-called psoriatic condition involves a systemic inflammation with significant comorbidities and needs a multidisciplinary approach in care. Arthritis in psoriasis, of course, can precede the skin manifestations or can be seen later. More commonly, the skin is seen first, skin changes are seen first rather than the arthritis. And of course, onset of arthritis affecting less than 5 joints is seen in nearly 94% of cases, that is oligoarthritis. The knee, the digits, the ankle, the hip, and the wrist, the percentages are mentioned. When you have a child with the skin psoriasis and an arthritis, and you have a family history of psoriasis, and you have seronegative situation, the chance that you are dealing with a psoriatic arthritis is very high. That is, in a nutshell, putting the Caspar score in practice. And when you come to the impact of psoriasis on quality of life, in adults it's well known that psychological problems, poor self-esteem, anxiety, depression, the absenteeism, presenteeism, so many things are involved, including suicidal ideation. In children, this can be even more. The visible nature of the skin plaques, the difficulty in socializing, disruption in family activities, disruption in sports, disruption in study, schooling. It requires actually a really major effort on the part of the psychologists, and the social impact in children is very significant. Itching can be quite difficult and intractable, not only in eczema but in psoriasis also. And stigmatization is a big issue in pediatric psoriasis. A significant impact in quality of life in pediatric psoriasis. And a brief outline about the pathogenesis. See, to put it simply, psoriasis is more common in certain families. There's a genetic role. Psoriasis is not seen in Indians in the South American continent. Psoriasis is more common in Faroe Islands. Psoriasis in monozygotic twins has a concordance of nearly 85%. And it's clearly demonstrated that there's a genetic element. If you knock out the T cells, for example, if you do a bone marrow transplant from a patient with psoriasis to a a person without psoriasis, you can induce psoriasis, and vice versa. If you transplant bone marrow transplant from a person who is normal to a person with psoriasis, you can clear psoriasis. Clearly, it's a T cell determined condition, and we have identified the genotype and the cytokines involved to a great extent. And the last 30 years has seen a very significant improvement in our knowledge about this immune-mediated inflammatory condition. And to put it in a nutshell, when you talk about history of psoriasis, the Human Genome Project, which was seen in the last late century, that is 20th century, and the discovery of monoclonal antibodies, that is which led to the current generation of biologics, which are protein molecules which can be either in the form of a monoclonal antibody or a fusion protein which target the cytokines or the receptors of cytokines, have changed the life of all our psoriasis patients. So when you come to the genotypes, multiple susceptibility genes have been identified, SORAS1, 2, etc., etc. A dysregulated immune system, and of course an environmental trigger. I don't want to go too much into it, but the clinical phenotype, the location, the molecular profile, and personalized medicines are very much in the cards right now. So depending on which part of the body psoriasis comes in, whether it is palmoplantar, whether it is a conventional, whether it is a scalp, the genotype is likely to be different, the cytokines involved are likely to be different, and we do approach a situation where we may have personalized medication. And I do predict that the name psoriasis itself might disappear in another 5 to 10 years, and we may start calling them as depending on the cytokine involved. And just a very brief talk about pustular psoriasis. I know this is a very specialized topic. Pustular psoriasis can be quite a devastating condition, and I will talk to you about this in private because I don't want to waste too much time on this. But the genotype, the phenotype, and the genetic markers are all well known now, and we can do genetic studies to actually personalize medicine in these conditions. I will go to the management. The issues about pediatric psoriasis are education of the patient, education of the family, the talk about the long-term nature of the illness, a strategy to reduce it and to decide on the right type of treatment for each and every individual patient, goal setting, treatment needs which are safe for a child and which can be monitored, and compliance, which is one of the most critical issues in pediatric psoriasis. Of course, it's a multidisciplinary approach, and the dermatologist, the pediatrician, the rheumatologist, and the psychologist, the dietitian, so many people are involved. The treatment challenges are that there are few actually studies in pediatric psoriasis, and there's a huge paucity in the guidelines, and most of the treatments are empirical in nature. But things are changing, and we are soon approaching a different era. So the mainstay of treatment are topical in nature, and phototherapies, of course, narrowband UVB in pediatric age group, and systemic treatments in case where topical therapies fail and phototherapy is either not suitable or is failing, is one of the most common strategies employed. Majority of children can be treated pretty well as long as they are compliant and we hold the hand of the child and the family, knowing that it's a lifelong condition, and we can achieve excellent results. Systemic therapy is indicated in only severe disease and in treatment resistant cases. Therefore, the critical step in treatment is to decide at what point of time a systemic treatment is required for a patient. So to be frank, a severe psoriasis is something which involves more than 20% of body surface area, has a huge PASI more than 20 or more than 10 with thick plaques, and a very significant impact childhood dermatology life quality index of more than 10. And in some cases, of course, even though it may be limited, but if it affects the face or if it affects areas where it has a huge psychological impact, we could classify it as severe psoriasis. And of course, the presence of arthritis makes a huge difference. Let me cut my talk short by, of course, steroids are used, Vitamin D analogs are used. Phototherapy is of course used still. Narrowband UVB is relatively safe. PUA is not recommended in the pediatric age group considering its carcinogenic potential, but in practice, patients coming on a long-term basis for phototherapy is quite difficult, even though you can achieve significant improvement with phototherapy. Vitamin A derivatives, for example, the systemic retinoids. The main issue about all the systemic therapies, immunosuppressive therapies in pediatric psoriasis are none of them are licensed. There is not a single systemic immunotherapeutic medication which is licensed for pediatric psoriasis. You may have a methotrexate license for juvenile rheumatoid arthritis or juvenile idiopathic arthritis, but not for psoriasis. Therefore, when we start a patient with severe pediatric psoriasis on an immunosuppressive, remember you are dealing with a non-licensed product and you are dealing with a child, and you may have to be really careful and take extreme precaution. Most of the medications have significant side effects. Retinoids, as you know, are teratogenic, and in a child of a female child of childbearing age group, you have to wean the child off for at least 3 years before it is safe for pregnancy. So there are various issues, and all these medications, for example, methotrexate, neotirazone, cyclosporin, all these are not licensed in pediatric psoriasis. So what is licensed in severe pediatric psoriasis? Surprisingly, the biologics are licensed, and the purpose of this talk is to make you aware that biologic treatments are licensed treatments of pediatric psoriasis, which have very significant impact on the quality of life and on the improvement in the psoriatic condition, and which can be sustained and maintained over a long period of time. And to tell you that, look, don't think that we don't have treatment for pediatric psoriasis now, we do have. And to put it in a nutshell, of the biologics currently, the TNF-alpha inhibitors like etanercept, adalimumab, and the IL-23 blocker ustekinumab. These are the 3 ones which are licensed for pediatric psoriasis. Etanercept from the age of 6 onwards in the European Union and from the age of 4 onwards in the USA. Adalimumab from the age of 4 onwards in this part of the world, including the European Union. Infliximab people do use, but that's off-label. It's not licensed for pediatric psoriasis. And of course, ustekinumab from the age of 12 onwards. I do believe they are doing studies for younger age groups also. But let me talk about adalimumab in pediatric psoriasis. So, as all of you know, adalimumab is a TNF-alpha inhibitor. It's a fully human molecule, and it has been used in adult psoriasis for quite a long time. It has been licensed for pediatric psoriasis, and you know that the dosage depends on the body weight in children. 15 to 30 kg children, initial dose is 20 mg, and then 20 mg after 1 week, and then bi-weekly. 30 kg onwards, 40 mg, followed by 40 mg every other week, starting 1 week after the initial dose. So this is a multi-center, double-blind, double-dummy trial of adalimumab in pediatric psoriasis. And to make it short, there are 3 arms, 1:1:1. Adalimumab 0.8 milligram per kg, adalimumab 0.4, and methotrexate. And surprisingly, this is the first probably study where methotrexate has been actually studied in pediatric psoriasis. Methotrexate, though we have used for umpteen number of years in psoriasis, does not have validated studies, and this might be one of the first ones actually which actually studied methotrexate also. Of course, there was a screening period, and patients were there's a lot of exclusions and inclusions. I don't want to go into all that for this audience. There was a period of about 16 weeks when it was studied, and then the drug was withdrawn, and the patients were watched for 36 weeks. And then patients were restarted for a retreatment. That is those who failed, that is those who improved initially, the primary endpoint and the secondary endpoint. The primary endpoint was a PASI 75 improvement in psoriasis, or a physician global index of 0 or 1, that is clear or near clear. There were a lot of secondary endpoints, and of course, unblinded teams were watching for side effects of psoriasis. So to put it in a nutshell, the safety and efficacy of adalimumab in pediatric psoriasis was studied, and as you can see, PASI 75 is achieved in nearly 60% of patients on 0.8 milligrams as compared to methotrexate, which shows a response of around 30. This is statistically very significant. So clearly adalimumab 0.8 milligram per kilogram body weight is definitely a significant improvement over methotrexate in pediatric psoriasis. The PGA did not show significant statistical difference in the improvement between adalimumab and methotrexate. Of course, the adverse events, infections, injection site reactions, worsening or new onset of psoriasis, these are all similar whether the patient takes methotrexate or any dose of adalimumab. And the side effects are comparable in all the three arms. So in summary, adalimumab is licensed in severe pediatric psoriasis patients from the age of 4 onwards, and if judiciously used, produces a really significant improvement in the quality of life of our patients. And as all of you know, the systemic nature of psoriasis with its significant comorbidities and the systemic inflammation induced by cytokines in psoriasis can also be tackled by this treatment. Thank you. I think you can go through the questions again. Most of the answers I have already given. Yeah. And do you want me to go through the questions? Or?
Yeah. Thank you, Dr. Srikumar, for an excellent talk, and the method of asking some questions in the beginning and then giving the answers later during the session was good actually. We at least will concentrate on which is more important, and we'll have some idea. No? So that's a very good idea. So actually, I want to know like what is the incidence of pediatric psoriasis in Dubai when compared to adult community?
Okay. The answer to this is very funny. So I'll tell you the answer like this. Diagnosis of pediatric psoriasis is not easy. So there's a huge number of patients who are diagnosed as eczema or as fungal infections and who actually have pediatric psoriasis who are missed. Therefore, the number of patients who are really diagnosed as pediatric psoriasis is much less than the actual prevalence. So you need to have an open mind about the diagnosis part. Second is, of course, there's a huge variation in the genetic genotype and the phenotype of psoriasis. And it is true possibly that pediatric psoriasis is much less common in the Indian or the subcontinental populations as compared to possibly Germany or UK. But I would say somewhere between 1 to 2% is quite possible still. Even 1% of the disease in the population is a huge number to live.
You are using?
Of course I'm using a lot in adults. In pediatric psoriasis, not so much. In pediatric psoriasis, they have to be really severe. I have used in 2-3 patients. But what happens, you know, as expats in Dubai, when a patient has a really severe pediatric psoriasis, they are desperate. They either admit the patient or they decide to go back to India. So there are 2 patients who I did start on biologics in pediatric psoriasis. Ended up going to India, and they continued advice with me on email and WhatsApp, but they were treated by my colleagues in India. But I do have experience of treating severe pediatric psoriasis patients with biologics, and they are doing pretty well.
Okay, thank you. Any other questions?
I think we should thank Agri for sponsoring this conference. And just 2 minutes of everybody's time, I believe Agri wants to tell us something.